This presentation is on antimicrobial agents. They are defined as drugs that we are going to be using to treat bacterial infections, and bacterial infections only, not yeast or fungi or protozoal or viral infections. And most of these bacteria, it's a large group of microorganisms that we need to deal with many shapes, sizes, and responses when we gram stain them, and that way we can differentiate them from one the other based on their cell wall characteristics. You can see there's many types of organisms: bacteria, microbacteria, viruses, fungi, and parasites. And so the two terms here, the types of antibiotics, knowing the difference between these two. The bactericidal is the ones that kill the bacteria directly, whereas the bacteriostatic inhibits the bacterial growth and eventually leads to death. They bind to the ribosomes and they decrease protein synthesis. Basically, examples of bactericidal is cephalosporins. Bacteriostatic would be sulfonamides. There is a difference in terms of these types of antibiotics between narrow spectrum and broad spectrum. Broad spectrum is it affects a wide group of bacteria, as you see, whereas the narrow spectrum kills very few organisms. So a broad spectrum would be gram positive is gram and gram negative both, and it would affect both of those types of bacteria. And essentially, bacteria have a very long half-life, so they can maintain a very high concentration at the binding site, and so frequent dosing is not required. And sometimes when you have an infection, you start off with broad spectrum bacteria until the culture and sensitivity comes back, and then you try to choose an antibiotic, or it may have to be changed to a narrower range. Most antibiotics bound to proteins, with some exceptions as ceftriaxone, clindamycin, oxacillin. They incorporate themselves into the cell wall and kill the bacteria. Basically, when we have a cold, we come in with a virus and maybe a sore throat, they could do a rapid antigen detection test that could tell whether it's strep or viral. But mainly, when you have an infection, you should wait for the culture and sensitivity so that we prevent resistance of antibiotics. The culture and sensitivity is needed to determine the type of antibiotic is needed for the infection. One size doesn't fit all. And if we don't do that, it ends up in antibiotic resistance, the ability to multiply despite the use of antibiotics. And it's what causes it is the antibiotic resistance is the choice of antibiotics that are not taking care of or vulnerable to that particular bacteria. And the patient doesn't take all of their antibiotic, but they stop it when their symptoms improve, and they use it as for viruses, as like the flu, when there is no infection. And you have to be careful. So with super infections, that's a term that you need to use when you're talking about the antibiotics. That's a new infection that appears during the course of treatment with an antibiotics from an overgrowth of organisms not susceptible to the antibiotic being used. There's nosocomial infections that are acquired in the hospitals, like, for instance, when we don't wash our hands very well and use proper PPE. And an opportunistic infection is organisms in the normal flora that become pathogenic when, like an overgrowth, where conditions are favorable, like in the GI tract with C. diff. And so there's many different antibiotics that interfere with the cell wall synthesis. The first one of these is the penicillins. Those don't all end in cillin, but most of them do. Penicillin G and V, amniopenicillins like amoxicillin and ampicillin. These are broad spectrum and they're both bactericidal and bacteriostatic. They enter the bacteria via the cell wall, bind to the protein, and disrupt the cell wall synthesis with an enzyme penicillinase. Penicillinase is possible for the person to be resistant to that enzyme. And so we keep the enzyme made by the bacteria to prevent the action of penicillins. Penicillins are pretty well tolerated. You want to assess the person's allergies to make sure they don't have a previous serious allergy, because then you would not want to give them cephalosporins. There's a cross sensitivity to cephalosporins. So like you'd ask them, have they had hives, throat swelling, difficulty breathing, shock type of symptoms with anaphylactic shock, hypotension, tachycardia, that type of thing. And so most of penicillins are very well tolerated. Most are effective against bacteria that rapidly multiply. The common adverse effects you can see is diarrhea is a main one, because it also takes care of the microorganism that the person is infected with, but also you have the normal flora that we have in our GI tract, and it alters that. You want to be sure in terms of electrolyte imbalance. You want to watch the potassium and the sodium, and you want to take it with foods and avoid fruit juices that affect its absorption. This is one of the ones that may interfere with oral contraceptives, so you want to take an alternate form of contraceptives with this particular category. And of course, because of the allergic reaction, you want to watch the patient for 30 minutes after administration. Very much this shows you the different things that the penicillin can act with, and like you said, that's it's both bacteriostatic and bactericidal. If the person doesn't take it, they're at risk for a opportunistic infection or an overgrowth. It shows you there the oral or vaginal candidiasis. Basically, that's the milky white curds in the mouth that can occur as a result of the antibiotics, and then you also have vaginal yeast infection that can occur. It's pretty sore when the patient has that. Thrush is another word for that, and so that the patient gets pretty sore with that. This next class of drugs is the cephalosporins. It's a family of drugs. It's really 5 different generations of this particular class of drugs, and each generation has a different antimicrobial activity. And these are both, just like penicillins, they're structurally similar to penicillin, so they're going to do some similar types of things. They are bacteriostatic as well as bactericidal. They're broad spectrum. Examples are cephalexin, cefazolin, ceftriaxone, and cetotaxine. Basically the same kinds of adverse reactions: diarrhea, similar to the penicillins, electrolyte imbalance. It can interfere with the oral contraceptives, and watching for any secondary infections. Most of these drugs metabolize through the liver and excreted through the kidney, so it's possible to, if the person has a previous liver disease or has a kidney disease, that you could have hepatotoxicity or nephrotoxicity. They're also very irritating to the veins and can cause a phlebitis, and so that we want to be sure to prevent the phlebitis, use their smaller needles, larger veins, like in the upper arm. Assess the site daily to look for the inflammation, the pain, the swelling. Make sure that it's patent, and put a new site every 72 hours or according to the hospital policy that you're in. Take the cephalosporins with food, and there's a cross sensitivity to both penicillin and cephalosporins, especially if the person's had a serious reaction to the penicillins. And so you would be sure to assess the person for that. Like you said, they can interfere with the oral contraceptives, and so you want to use additional methods like condoms or foams during administration. If you're giving it to kids, you want to be careful to, if you'll be using liquids, to use a calibrated oral syringe. Shake it up and be accurate. Don't use household spoons when you're measuring it out for those folks. And one of the things, you don't want to take it with alcohol, as it says, it can cause very similar to a disulfiram reaction, like when we take disulfiram is antabuse, and when the patient who takes it to deter them from taking alcohol, very similar when you take cephalosporins, it has that same kind of reaction. It causes the flushed face, dyspnea, tachycardia, and low blood pressure. So alcohol is in mouthwash also, so you want to caution the patient to do that. It causes a low prothrombin activity also. It depletes the vitamin K in the gut, so you also, if the patient's on warfarin, you want to assess their INR or their PT, whatever the patient's on. It shows you here the cephalosporins, the different families of cephalosporins, and the family reunion, watching out for diarrhea, which is a side effect in secondary infections. Rocephin, like you said, is one of the medications that is in this particular family. In terms of Rocephin, you want to, sometimes they use it for surgical prophylaxis. It's usually given within 16 minutes after the first incision, so it gives the patient time to have serum concentrations reached. It shows you the trade name there, Rocephin, but it's ceftriaxone, which is the generic name. This particular category of antibiotics isn't used very well often. It's bactericidal. It's active against gram-negative bacteria. It's a synthetic antibiotic. This next category, carbapenems, one of the ones we use most often is imipenem and silastin. The trade name is Primaxin. And of course, in your test, you're just going to get the generic name. So you want to learn it by that. The silastin, as part of that two compound group, has no antibiotic activity. It prevents the inactivation of imipenem by the bacterial enzymes. The carbapenems are extremely potent. They're very broad antibacterial action. The patient can get resistance to the enzyme secreted by the bacteria, so there can be antibiotic resistance, and they infuse over 60 minutes. You see the same types of side effects, very serious diarrhea there, but seizures too. Low doses can prevent some of that from occurring. They also have a cross sensitivity to penicillins and cephalosporins, so you'd want to ask the patient if they've had a serious reaction to either of those. The reason why there's a cross sensitivity, they have the beta lactam ring in terms of the nucleus, the membrane that surrounds the nucleus, so there's a cross sensitivity can develop since they have a similar chemical structure. Vancomycin is a drug that we use. It's readily used for patients that are allergic to penicillins and cephalosporins. It's used to treat MRSA and other gram-positive infections like C. diff. It's given over 60 to 90 minutes IV. If it's given too fast, the person can have hypotension. They can also have what is called red man syndrome, very similar to that other reaction I was talking about, the flushing. of the upper trunk and face, but it also can have itching of the head. But an antihistamine reduces this adverse effect. You see that it also can cause ototoxicity and nephrotoxicity. Ototoxicity would be the person would have some buzzing or ringing in the ears, tinnitus, and then they could have, in terms of an adverse effect, you want to watch dehydration in the older person, and you want to monitor blood levels to prevent some of these toxic effects. The nephrotoxicity with somebody with kidney disease, ototoxicity. The drugs that inhibit protein synthesis, the tetracyclines, the macrolides, and the aminoglycosides. The tetracyclines, we use it, and you see some of the different uses there on the slide: urinary tract infections, respiratory infections. Sometimes we use it for acne. So there's quite a bit of uses for the tetracyclines. One of the things, it causes abdominal cramps, and it can cause liver toxicity, photosensitivity. It is bacteriostatic, so it binds to the ribosomes, preventing the transfer RNA to the messenger RNA, and it reduces the proteins. It's not used as much now because there's a lot of resistance to it. You want to be careful that you don't give it with antacids or milk because it decreases its absorption. You see very serious side effects, especially with kids under 8, and because of the fact it can discolor the teeth. It interferes with enamel development also, and the discoloration can be permanent. If women are breastfeeding, they should use cow's milk or formula because it can also affect the children then. You want to give it on an empty stomach with a full glass of water, and it can also retard fetal skeletal development if taken during pregnancy. If you're taking oral contraceptives, you want to take another form of contraceptives because it can decrease its effectiveness. As you can see, the tetracycline is effective against gram-negative and positive bacteria, and can be effective against mycoplasmic types of infections as well. It cautions you about the tetracyclines in terms of during pregnancy because of the effects on the fetal skeletal development. The macrolides are, the action, as you can see, it is bacteriostatic and bactericidal, only bactericidal in very high concentrations. Erythromycin, it's has a very bitter taste, and it's quickly degraded by acid in the stomach, so there's different forms developed to prevent this. And one of the newer drugs, azithromycin, can be given, it's given less frequently, and it has high antibacterial activity, and that's in this particular category. It also has ototoxicity, so you want to check the patient for hearing loss, vertigo, tinnitus, and it's usually only used when the penicillins, cephalosporins, and tetracyclines are contraindicated. You want to, in terms of nursing implications, give it with a full glass of water on an empty stomach, except azithromycin can cause some stomach effects. Enteric-coated doesn't have to be taken with any particular food. Drinking with grapefruit juice can increase the adverse side effects of the drug, and you want to watch its interactions in terms of increasing the blood levels of digoxin, can cause toxicity, warfarin, bleeding, and theophylline, some difficulty there. So if they're on warfarin, to check the INR. international ratio to prevent clotting. And it can cause dysrhythmias. Its effectiveness when they're taking oral contraceptives, just like some of the other antibiotics we've talked about, is decreased. So you want to use other forms of contraception with this one as well. This talks about azithromycin. And again, it mentions the superinfections that can occur as a result of the normal flora being decreased in the body. And aminoglycosides is another category. It's bactericidal. They're usually given parenterally. They're poorly absorbed through the GI tract. Neomycin is an exception to this, which is given oral or via an enema type tube. Gentamicin is the example of that. It can cause ototoxicity, as you see, nephrotoxicity, especially someone with decreased renal function. So the patient needs to be monitored to prevent these toxicities. Of course, the metabolites with a person with renal disease, since it's excreted through the kidneys, you'd have to watch the BUN and creatinine and check them for ototoxicity signs, the hearing loss, the vertigo, tinnitus, and check the peak and troughs on the medication to see whether it's effective and what the blood level is. Aminoglycosides, it shows you the mentions in bold, the ototoxicity and the nephrotoxicity there. And the next drug we don't give quite so often, the fluoroquinolones. Ciprofloxacin is an example of that. It's bactericidal. It interferes with the enzymes of the bacteria necessary for DNA synthesis and replication, and so it interferes with the replication of the bacteria. And the quinolones, we should not give it to a child under age 18. It causes erosion of the cartilage in the weight-bearing joints, so it shows you there, don't give it to pediatric patients. It causes photosensitivity, so you want to avoid sunlight. You don't want to give it in enteral feedings because it sticks to the inside of the tube. Some of the nursing interventions that you want to assess an older adult for any confusion. Giving it with antacids, iron, or dairy products can decrease the absorption. You want to give it lots of fluids to prevent crystallizing in the urine and preventing any occlusion, any stones. And give it with food to decrease GI upset. And you want to watch any patient who's on glyburide for hypoglycemic symptoms. This slide shows you, again, watching a client for superinfections. Drugs that interfere with the folic acid, like sulfonamides, sulfadiazine is an example of that. There's a combination drug that is trimethoprim slash sulfamethazole, TMP slash SMZ, sometimes it's abbreviated as. This category is bacteriostatic. There's a lot more resistance now because it's used quite often for patients. So because of the resistance, we can't use it quite so much. It's not as effective. And it shows you here that it causes photosensitivity. And in terms of the nursing interventions, you want to give it on an empty stomach with plenty of water to prevent crystal and stone formation in the urinary tract. To maintain an alkaline urine will also prevent some of that crystallization. So sometimes it's given with sodium bicarb. Avoid sunlight because it causes photosensitivity. You don't want to mix other drugs with it in the IV lines and give it over 60 to 90 minutes. Some of these other categories, the antiparasitics or the protozoals, it's a broad spectrum bactericidal. A lot of times it treats, like it shows there, C. diff, H. pylori, and it's usually given with the tetracyclines for that. One of the ones you'll see most often is metronidazole or flagell. It damages the DNA. You see that it can, it's harmless, but it causes a metallic taste in the mouth and darkens the urine. So you want to tell the patient about that because they could get alarmed about it. Give it on an empty stomach for best absorption. You want to look at the other drugs the patient's on in terms of the med reconciliation to make sure there's no drug interactions. When you're giving it in the IV, it can be incompatible with quite a few things, so you want to go to your micromedics to make sure of its compatibility. No alcohol of any kind, because it can cause that disulfiram type reaction, the flushing, the tachycardia, dyspnea, vomiting. And it also inactivates warfarin, so you want to, that's one of the major interactions. And this shows you here no alcohol products. And up to 48 hours afterwards. The antifungals is another category. Amphotericin B is one that we use most often. Nystatin, the swish and swallow for the yeast infection, the thrush that's in the mouth. And it causes cell death. And you can see that it also causes thrombophlebitis, so you want to watch the IV site. Can cause nephrotoxicity. You want to be watching the INO, the BUN, the creatinine. Sometimes prior to therapy, if it's causing any kind of a reaction, give Benadryl and Tylenol. Usually what they do is give with the amphotericin B, they give a very small test dose beforehand to make sure that the patient doesn't have a reaction to it. And the nystatin, it treats thrush. And then the antivirals, as acyclovir, prevents the reproduction of the viral DNA and thus disrupts the cell replication. These cause thrombophlebitis, so you want to rotate the IV sites and do some of the other things to prevent phlebitis that I already mentioned. It causes nephrotoxicity, so you give it slowly over an hour, and you make sure that it also causes gingival hyperplasia, so the patient should seek dental checkups and you want to check them out. If it's given topically, you want to put on gloves and prevent the transfer to your hands. And keep the lesions washed 3 or 4 times daily and keep them dry. So those are all of the drug categories. Basically concentrate on the antibacterials. But I wanted to briefly go over some of these other categories.